Okay, ladies and gents, I've just started the recording of the webinar, so this will be available after the presentation if you need to refer back or if there's anything you missed or to go over. Same for anyone who has joined the webinar and missed the start and is now looking back over the recording. Don't worry, we'll be covering everything here. If anyone has any questions, do pipe up, but there will be a Q&A at the end if you need to get anything more substantive answered. Okay, it's 6:30, so I think we are going to kick off. If anyone has any issues with viewing the webinar, do just pipe up and let me know. Okay, so we're going to be running through today some basics you can expect on the OSCE in terms of how you should present yourself and the basic structure of the questions. We've also got Dr. Emily McGregor, one of our clinical leads, who will be joining us to cover any clinical content and answer any clinical questions you have. Usually we'd run through all of the format of the exam first and then move on to subject-specific revision advice, but Dr. McGregor is on a limited time schedule tonight, so we're going to just have the basic introduction and then we're going to move on to some of the essentials that you'll need to know to prepare yourself for the OSCE and to avoid any of the basic pitfalls that can threaten your ability to pass the exam confidently. If you've been tackling your FAQs and you're a bit concerned about the difficulty, do rest assured that the OSCE is much more straightforward than the SAQs, which can present more of an obstacle to students. So please don't be too worried. It's a very straightforward examination, which is focused mainly on testing your safety rather than your academic excellence. Okay, so I'm going to jump on to some basics first. The OSCE will be held at Leica Health Canary Wharf. If you've never been there before, do look up your route before. It can be a little bit tricky to find your way there as it's a split level part of Canary Wharf. So do just have a look on Google Maps how you'll be getting there, and do try and arrive half an hour before your exams start. The times I've sent out via email outline both when your exam is starting and when you should arrive half an hour before. Do please bring a form of photographic ID with you, as we'll need it to verify you are who you are. If you forget it, don't worry. Just come and ask one of the staff members on the day. And please be aware that the OSCE will be recorded using video cameras and microphones, as this is a stipulation on Ofqual's part to ensure that all marking decisions can be upheld at moderation. Okay, so I'm going to jump straight into some of the key elements of the OSCE, which will run you through the types of station that you'll be facing, as the exam is split up into 8 15-minute stations of 15 minutes. I'm going to hand over to Dr. McGregor to run you through. Someone's got quite a lot of background noise going on. If people could mute their microphones when possible to avoid too much noise coming down the line. I'm going to pass over to Dr. McGregor, who will be able to run you through some of the basic topics on the OSCE, starting with dermatology. So I'll pass over to you, Dr. McGregor.
Thank you, Ben. Yes, so I can see that some of you have muted yourselves and some of you haven't. If you, on your circle on the left-hand side, there's a green microphone button. If you just press that and mute yourselves, then all of your background noise won't be heard by the group. Thank you. Perfect. Yeah, you've pretty much all done it now. So there are 8 stations, as Ben said, and they will be split across some practical procedures, some consultations, and a few other bits and pieces. What I can do is talk you through things that have come up in the past. I'm not personally one of the assessors. The mentors are not allowed to be the assessors for obvious reasons, as stipulated by our exam board. So I can talk you through what has come up in past exams and what is likely to come up. However, there could well be some variation on the day. First thing I'm going to talk to you about is the dermatology station, which may come up. It will not be the bulk of the exam. It is an injectables qualification, but you may get one station on dermatology. If you do, the first thing I want you to be aware of is that we know you're not dermatologists. We don't expect you to have in-depth medical dermatological knowledge. However, we do expect you to know the basic cosmetic dermatological conditions that you might come across commonly, and also to be aware of dangerous dermatological conditions. What this means is that out of all your kind of wealth of information in your e-learning, it's a good idea to just cover the basic common things: acne, melasma, sun damage, things that you're going to see on your aesthetic clients all the time, and should at least be able to recognize and have a simple idea about how you may manage. And then also dangerous things, which is malignancies. So I would recommend being able to recognize these visually and be able to know the basics of how you might manage them and what patients might be suitable for treatment. The stations could involve you talking to an actor, which would be this assessor, so it could be a consultation, or it could involve looking at some photographs. I don't know the details, but I would don't disregard dermatology, but equally don't go into lots of detail about the physiology, and anything that comes under the umbrella of medical management, for example, management of psoriasis, lupus, etc., is not something that that I think would come up in this assessment for injectables. Moving on, so yeah, consultations. You'll definitely have at least one, probably 2 or 3 consultation stations. As Ben said, the focus on the exam is for us to assess your safety as a practitioner and your professionalism, not to test the kind of minutiae of your knowledge. So a consultation is really just what you've been doing, should have been doing in your mentor clinics. It's taking a history. And in that history, your patient will be your assessor. So there won't be any actors. There'll just be one person to talk to who is your assessor playing the role of a patient. On the one hand, this is good because it means that the person you're talking to is very well scripted. They know exactly the role they have to play and it will be identical for every student. On the other hand, it might require a bit of an imagination because, for example, you might have an older male assessor playing a 21-year-old young lady. So just go with it in kind of OSCE fashion and talk to them as if they are your patient. When you're doing your consultation, the important thing is to not miss any safety features. And these are things that we know that you would ask about: allergies, drug history, contraindications such as pregnancy, breastfeeding, and severe mental health problems. But often in a clinic scenario, this is something that you might have written on a medical history form. Whereas in your OSCE station, you'll have to make it explicit that you're asking each section of the history. I think there should be blank paper provided and a pen, so if you want to make notes, you can, but these are purely verbal assessments. In view of that, it's helpful for your examiner if you make it obvious what you're asking. So if it was me, what I would do is I would ask about why they've come today, the history of their presenting complaint. Are they well generally? And then I would say, I'm just going to ask them specific things to check that it's safe to treat you. For example, do you have any allergies to any medicines? Do you have any muscle disorders or immune disorders? Are you currently breastfeeding or pregnant? And do you have any mental health conditions? So mental health history is part of your medical history, and it's something that you would ask every patient, whether on a piece of paper, on a form, or verbally. So I wouldn't shy away from that. It is important. You have 15 minutes for each station, so you have more than enough time to perform a consultation. And in that consultation, you'd not be expected to demonstrate the treatment within the same session. So it would purely be taking the patient up to the consent phase. So it's just the information collecting phase. Alternatively, there might be a slightly different slant on the consultation, which would be explicit to you in the instructions. So the instructions may be very general, such as this 25-year-old lady has come for a consultation, in which case you start from the beginning and see where her history takes you. Or it may be something more specific, such as this 40-year-old lady has concerns about the long-term risks or the risks of toxin treatment. And then you'll be more guided by what the question is telling you. But if there's any tip that I can give for you, it would be to absolutely not miss out on any contraindications. Okay, so we'll move on to the next kind of station category, which is a treatment simulation. It will make sense for you to have at least one filler and one toxin. I suppose you could have 2 of one modality or 2 of each. The treatment simulations are all on the mannequin heads, so you don't have to worry about injecting any real people. Given that they're on the mannequin heads, clearly we are not able to assess for results regarding the filler treatments, so you don't have to worry about that either. What we want to check is that you know how to go through the process safely and perform simple treatments for toxin in a license according to licensed guidelines, and for filler in a safe manner. So I'm just going to quickly talk through each modality. So for toxin treatments, we're only assessing you on the upper face treatments, which would be the frontalis, the glabella, and the orbicularis oculi. The course is not brand specific, and what that means is you'll have probably a placebo vial of toxin, or it might be a branded vial, either Botox or Bocature, but the point is that vial of botulinum toxin can be whatever brand you want it to be. If you're familiar with using Botox, you could say, I'm using Botox and I'm reconstituting XYZ, or I'm using Bocature and reconstituting XYZ. Or if you are, we may have a few students, not many, who are much more familiar with Azelur, then even that is absolutely fine. As long as you reconstitute it and use the dose according to the product guidelines or to what's sensible and safe in common practice, then that's fine. I would definitely verbalize what you're doing though. For example, I'm reconstituting with 2.5 mils of saline, I'm mixing the product, I'm withdrawing 0.3 mils, 12 units of product, etc., etc., so that the examiner doesn't miss any part of what you're doing. Likewise with filler, we're not brand specific. You may have placebo filler, you may have branded filler. If you have branded filler, it would probably be Merz Bellatero range. However, if you're not familiar with Merz Bellatero range and you use Juvederm, that's not a problem. You would just choose a filler and say, I would select a filler suitable for whatever it is you're doing. So a filler suitable for a volumizing filler suitable for periosteal injection, or a middleweight filler suitable for lip augmentation. What we need to know is that you are aware that there are different dermal fillers with different properties appropriate from different areas. We don't need to know that you know which one to select from a given product range. And when you're doing your injections, we're looking for sensible, safe injection techniques, but we're clearly not assessing the result, the aesthetic result on a mannequin. So don't worry about that either. And again, 15 minutes is more than enough time to perform one treatment on a mannequin. So you can really go nice and slowly, check each step off in your mind. And if you're stuck, you know, your assessor's there for you to ask questions. I think that's it, yeah. So there's likely to be a conversation on complications management. And the most serious complication in aesthetic medicine other than anaphylaxis is acute vascular occlusion from dermal fillers, in which case you would have to use hyaluronidase. I don't know that this will come up, but it has come up every previous OSCE, so I suspect it will. So you should all, if you're already injecting filler in your own practice, have hyaluronidase. If you're not, you've probably all seen it. Most practitioners will practice fillers regularly for years, and they will never use this acutely. I've actually never used this acutely, but I know how to, and that's all you need. So you will have a vial, maybe a real vial, maybe a placebo vial, and the assessor will want to see that you know what to look for if you're a suspected filler complication, and what to do, and that includes diluting up the hyaluronidase and using it. There are some guidelines out there. The ACE group guidelines are very good, and they're ones that we tend to recommend, but there is no absolute consensus on what you do in this situation, on how many units you use. We want to know that you understand that the principles, which is recognize the situation, in a timely fashion, dilute the hyaluronidase into a sensible amount of saline, anywhere between 1 and 10 mils, and inject it into the area that you think is suffering from an occlusion. And following other simple steps like keep the area warm, take photographs, reassure your patient, check for response. If it's not responding, use more hyaluronidase. So they're general principles we're testing. The number of units you're injecting, the exact injection method is not the important point here. So I would have a look through the ACE group guidelines, which are, if you haven't already, it's an open access PDF that you can just get from Google, and have a go of that in your mind. Obviously, it's not something we will expect you to practice lots of times and done before. We are aware of that. Yeah, next one, Ben. And then facial assessment. So this you may have done in your OSCEs in your mentor sessions with your mentor. Really, the facial assessment is an opportunity for you to show your assessor the different treatments that you're aware of in the field of injectables. You may have a patient or you may have a photo of a face, and we want you to be able to, in a systematic fashion, talk through a face in terms of any concerns that they have with their skin, their muscles, their bony structures, their fatty structures, where they are in the aging process, and propose different treatment possibilities. In this scenario, obviously in a real consultation, you would tend to do this sort of automatically in your mind and tailor what you say to your patient according to what they want. In an exam scenario, I would really just bring forward all the information that you have. And what I mean by this is, even if it's a treatment that you can't personally do, like tear trough filler or masseter toxin, I would still mention it because it's showing an awareness of the injectable options out there and what they can do. So one distinction I'd like, and this is showing that you're more than just a practitioner that can use Botox to take away forehead lines and filler to make lips bigger. We kind of want you to demonstrate that you understand how to do a full face assessment. And in particular, what that means is that you understand that both modalities can be used for two different things, lines and wrinkles and shapes and facial shape. For example, dermal filler can be used for simple wrinkles and folds, like your nasolabial folds, but it can also change facial shape and structure, for example, by enhancing the chin or the cheekbones. Botulinum toxin, commonly just used to smooth out wrinkles in the upper face, but it can also be used to change shape and structure, for example, slimming the masseter muscles and changing the jawline profile. So go systematically and talk through I would just talk through any treatment indication that you think might be possible. And if you're not sure, then ask your assessor. Okay. So Ben is going to talk through all the practical things like what to wear, where to go, forms, pencils. Sorry, Ben, if some things I've missed. But there's a wealth of logistical information. And he's probably the best person to ask for 90% of your OSCE questions. But if you have anything, any clinical questions to put to me now, then I'm here to answer them.
Exactly. Thank you very much for that, Dr. McGregor. Emily's taken you very thoroughly there through the vast majority of everything that you're going to be asked on the day, and certainly through all of the points that you need to be concerned about. The only real sort of worries you need to have going into the OSCE are things like making sure that you've checked people's drug histories, making sure that you've performed thorough assessments that involve facial shape and folds or wrinkles. In all other regards, as long as you're showing those basic safety tips, you are not expected to be sort of a high-flying, a top-tier practitioner. This exam is not about checking whether or not you are the best of the best. That's more what the SAQs do. It's about making sure that you're safe, because that's what the GMC and the other councils are interested in the light of the KIA report. So I'm going to run you through some basic logistical.
Ben, sorry, just because I might have to shoot off by 7. Can I just see if any students have any clinical questions that you can't answer?
Yeah. Does anybody have any questions relating to clinical procedure on the day? If there's anything that comes up later on after Dr. McGregor's had to go, don't worry. We can answer them by email in the morning. But if there's anything on anyone's mind right now, do please jump in and let us know. I'll just jump through Dickie.
Hi, it's Adam Colston.
Hi, Adam.
With regard to the dermatology section and talking about some of the basic skin conditions and stuff like that, in terms of how they ask you these questions, are they going to say, show you a picture of a skin condition and expect you to expound on it in terms of how it develops, what the causes are, what creams you need to apply to deal with them, whether they need biopsies or certain types of excision?
So things in the realms of biopsies, I would put under medical dermatology, and I would not expect sort of a basics injectable practitioner to be aware of that. Obviously, like I said, I don't know 100%. I don't know what's coming up in the OSCE, but from all of our previous OSCEs, it's about recognition and recognition what's safe to treat and what's not safe to treat, and also how it impacts the patient. So something like acne, that you might be expected to know the absolute basics of non-prescriptive treatments. But anything that requires prescriptive medical therapy as the mainstay of the management of the condition, I strongly doubt you'll be expected to know about. The only treatments that within medical dermatology that may come up purely for safety reasons is malignant lesions, and not the management, but just knowing to identify, knowing not to treat, knowing to refer on.
Okay.
Exactly right there. I'd expand on that to say that as Emily said there, you don't need to know any treatment options for skin conditions. All you need to say is you'll be shown a picture of a condition, and you simply have as long as you want to have a look at it, and then you need to say, I think this condition is X. So if you look at psoriasis, you'd say, I think this is psoriasis, and then you need to explain, broadly speaking, what that condition looks like, its visual impact on the patient, and then simply talk about whether you think it's a contraindication to treatment.
Okay, that was something that I wanted to. The other question that I had was regarding the facial assessment. Mm-hmm. Obviously, 3 upper face toxin, all the main areas for filler, and including chins and cheeks and masseters for toxin. But there are also sort of like strange uses of toxin, which were in the online training, but quite frankly, I've forgotten them, which are things like under the eye, near the lower eyelid, and stuff like that.
When it comes to more exotic treatments, you don't need to know dosages, you don't need to know indications. You simply need to talk through them as options. This is so that the exam board are keen to see that you can't just work as an independent injector, but you're also able to recommend treatments to patients if you think that they're called for, and sort of suggest them as options. You're not expected to be able to
like gummy smiles and
there's no treatment that you will be marked down for mentioning.
Okay.
Wait, so you won't be not marked down, but I imagine that it will be more demonstrating a knowledge of off-license, perhaps lower face toxin treatments. So mentioning 1 or 2 would probably be sufficient. If you missed one off a list, I doubt that would matter. But showing that you have a knowledge of more than just upper face treatment is a good idea.
Okay, cool. Thank you.
Fantastic. Thank you for that. Those are poignant questions, Adam. Does anyone have any other points that they want to raise on a clinical point of view? If it's logistical questions, do please save them for the end.
No? Okay. I'll say goodbye and good luck.
Fantastic. Okay, thank you very much for joining us, Dr. McGregor. If anyone else has any questions that come to them later, send them through to email to me, and I'll pass them on. Fantastic. Okie dokie then. Everyone still hear me okay? Right, let's get back then to some basics of the format of the day. So the OSCE is split up into 8 stations. Each one is 15 minutes long. You'll be brought into a hallway. You'll be given 2 minutes to read a station, which is listed on a piece of paper. It tells you what you'll need to do. And then you will head into the room. You'll have 15 minutes to complete the task, and the tasks are always completed orally. There's no written element, and the treatments are always simulated. There are no real patients involved in the exam. And then you will come back out into the corridor after your 15-minute station, have 2 minutes to read the next, and so on and so forth all the way through the circuit. The exam is, as Emily has already pointed out, product neutral. So don't worry about knowing the dosages for every product under the sun. Okay, so in terms of how you need to conduct yourself on the day, you should adopt a professional approach. This is a simulation of a professional treatment, so always give a professional introduction when you enter the room. You can break character, as it were, to talk to the assessor. You won't be marked down for that, but whenever you're directing your commentary as if it were to a patient, make sure that you are professional and respectful. Describe your actions whenever you wish. If you're injecting, there is no sort of description that will be considered too simple, and you will never be marked down for over talking. So if you're thinking something through in your head, explain it to your examiner. They won't always necessarily be able to answer questions you have. For instance, if you ask, is this filler appropriate for this treatment, they won't be able to guide you. But it never hurts to ask. And when it comes to more logistical questions, they'll be able to help you out. And always remember to be explicit, be clear. Try never to be waffly. Always be very, very particular and draw attention to things very closely. For instance, we were talking about facial assessment there. And if you're talking about recommending a masseter treatment, why are you doing so? You're doing so because you want to bring the patient's awareness to the fact that toxin treatments can be used to reshape their face if perhaps they're not keen on filler treatments, or if they have a square jaw and want a more, especially in female patients, if they want a more feminine jaw.
Can I just interject a question quickly?
Yeah, of course.
With regard to the facial, the aesthetic facial assessment, will that be will we be shown a photo, or will it be the examiner's face that we're essentially? It'll be a photograph.
It'll be a series of photographs actually to show range of motion and angles depending on the treatment it's asking you to recommend.
Right. So so the facial assessment, you see them, you make the assessment, and then for example, if you were doing it and they you could sort of see sorry, I'm burpling now. You would be able to see what their eyebrows lifted up and frowning.
Yeah, exactly. And there won't ever be a detail that's not. If something isn't included on a photo, you don't need to mention it. The key with the facial assessments, the best way to approach them is they'll always be modality specific. So it'll always be for fillers or for toxins, and just make sure that you are assessing both shape and folds for fillers or wrinkles for toxins. People often use shape.
And you don't mention the other one.
Sorry, you don't mention the other modality?
Yeah, you don't. Yeah, no, you don't. Yeah. So, for example, if it's an assessment for toxin, then aesthetic facial assessment for toxin, you don't mention fillers at all in that.
No, there won't be any marks mentioning fillers, but crucially, you won't be marked down if you do mention fillers. You don't get negatively marked based on misunderstanding the question. The only time that marks are deducted is if you show lack of safety. So if you inject in a vastly unsafe way, if you forget to talk about someone's allergies in a consultation, those sort of unsafe steps are the things that can cause marks to be deducted. But if you make a mistake, so you're going through a filler treatment and you going through a filler facial assessment and you start talking about masseters with toxin, you won't be marked down. It's only safety that the exam board are concerned with.
Okay, great, thanks.
Okay, so I am going to reiterate some points that Emily said. When in doubt, make sure that you have your key steps in, particularly with consultation. Talk explicitly about mental health. Talk explicitly about drug histories. Talk explicitly about allergies. Those three are absolutely key. If you do not bring attention to them, you won't be able to pass the station because you aren't demonstrating proper care for patient safety. Similarly, if you are asked to talk through a station regarding contraindications, because the consultation stations can often be in the vein of a patient is concerned about X or Y, talk them through some of the risks associated with filler treatments or toxin treatments. Make sure you're thorough. So a key one is if you are talking someone through the contraindications for filler, if they are female, regardless of their age, discuss pregnancy and breastfeeding. Also ask them if they've had any infections recently around the site that they're injecting, so that you can be sure that you're not recommending an injection to a herpes lesion or anything along those lines. As long as you're always explicit about safety, you're going to be absolutely fine. Now, people often find they have questions that come to them after they finish watching the webinar, and if that happens, don't worry. Just get in touch with me via email, and I will reply. This will be available as a recording afterwards, so you can always look back over it and revise anything you're unsure of. Does anyone have any questions about the OSCE on any topic whatsoever? Please be aware that most of your microphones are muted, so you'll need to click the unmute button if you want to ask a question. None at all? No, nothing from. No. Okay.
Sorry, Ben.
Oh, hi there, Farhan.
Hi, sorry, Ben. Just a quick one. In the last webinar, I didn't get to attend the last webinar, but I was listening to the recording.
Yeah.
There was a question about whether there was any possibility of seeing previous videos
Yeah. We reached out to our exam board, but because the videos and the mark schemes are still pertinent to exams that are in circulation, we are not allowed to release them under any.
Right, fair enough.
Ofqual are extremely inflexible when it comes to active exam papers, I'm afraid. So if you have any questions, we can absolutely make them available to you. We can make advice available to you, but I'm afraid that we can't send you any of the videos, all the mark schemes for the exam.
Right, no, but just on the back of that, in terms of the consultations, I know we practice them during the mentoring sessions and whatnot, but as what I'm getting at is obviously there's different types of consultations that people do, but you know the consultation forms that Harley Academy use to do their actual consultations with patients, is that a good basis to work off, or would you recommend some other form?
That is a good basis. I can run you through the key elements that should be involved in any consultation, which is probably good to be explicit about. So we've already talked about your safety elements. You've got to take a broad medical history, talk about drug allergies, talk about allergies, talk about drug history, and talk about mental health history. You need to seek informed consent very explicitly. Make sure you give the patient reflection time when you've formulated a treatment plan for them. Run them through any concerns you think they might have, and make sure that they understand all of the risks involved and have definitely given informed consent explicitly. And as long as you've touched on those points, broadly speaking, you'll be absolutely fine. If you want more guidance, some of the questions will have what's called a mapping to specification box printed on the question.
Yeah, you mentioned.
And the mapping to specification box outlines a series of sort of sub points that the exam is looking for you to discuss. So, for instance, with the consultation, one of the mapping specification boxes will be formulate a pre-treatment care plan. So that means that you need to tell the patient what it is that they need to be expecting. You need to seek their consent, and you need to run them through a suggested treatment. And then you also want to give them post-treatment advice. So you want to provide them with an emergency contact detail to contact you on. You want to advise them not to use makeup or perform any strenuous exercise for 24 hours after treatment. It's the real basic key stuff. There aren't really any sort of trips in the OSCE. It's all pretty self-explanatory. As long as you're being really thorough, you should be absolutely fine. So the key watchwords are making sure you're explicit and thorough, and making sure that you're safe above all else.
Right, brilliant. Thank you.
Fantastic.
Will you be expected to come up?
Sorry, Adam.
Sorry. Yeah, will you be expected to sort of at the end of the consultation to come up with the plan, so to speak? I mean, in the sense of will the examiner, for example, throw in something that makes it less likely that you will treat that person?
Potentially, you should always be aware of potential contraindications, and if you think you've seen anything that's contraindicated, you should express it.
Okay.
But yes, you should. If the question asks you to, you should formulate a care plan. Okay.
And with regards, you mentioned reflection, time for reflection, cooling off it. I mean, it's meant to be 2 weeks. I never saw that during any mentoring session that we did. But with regard to that, how do you express that within the OSCE?
So a good way to express it, just as in a time-stressed clinic, a good way to do it is to simply ask the patient really quite openly and not in a sort of throwaway way, but in a slow and methodical way. Do you have any questions? Is there anything you're concerned about? Really stress the point that if they have any concerns, they're welcome to raise them. Don't sort of run through things as a rapid checklist. Always try and say, are you comfortable with this? If you have any concerns, you can always get in touch. Of course, you won't be going straight into the treatment in the OSCE consultation, because it's just a consultation station. So in the context of the OSCE, you can say, here is our care plan. We'll carry this out at another time. Please make sure that you think about the care that's been suggested for you. And if you have any concerns, get in touch. Great.
Another question. With regard to adverse outcomes and complications, on the MERS form, it sort of gives quite a lot of detail with regard to that. You know, sort of 1 in 10,000 people may experience this and that, but we're not expected to do it to that level, are we, during the OSCE?
No, you don't need to sort of have the exact numbers in front of you, but you do need to say that, you know, there is a risk of vascular.
These are common, these are rare, these are even rarer.
Exactly.
Okay.
Exactly. The exact numbers don't matter, but the actual risks certainly do.
Okay, thank you.
Lovely. Okay, does anyone have any further questions? Nothing whatsoever. Okay, if anyone's having problems with their microphone or anything along those lines, drop me an email. A recording of this will be available. I'll send it out to all of you tomorrow. Thank you very much for joining us. I'd say thank you to Dr. McGregor that she has left the building. And thank you very much for attending. If you have any queries, don't hesitate to get in touch. And best of luck for your OSCE if it's coming up on Saturday. Okay. Have a good evening, guys.
Thank you very much.
Okay, bye.
Bye.
Thanks.